Great. So I'm going to open up the course with our first speaker, Dr. Livingston, who's going to talk about lower limb differences in children. We're probably 3 minutes ahead, which is not a bad thing, but perhaps we could just get set up. And Kristen, whenever you're ready, we can start, and we'll probably have some time for discussion towards the end of this session, so that'll be great.
All right. Thank you, Sanjeev. And it's an honor to be with everyone today with this amazing international group. So I'm honored to kick us off this morning. I'm going to be talking about a very general topic, causes of limb differences in children. And as Dr. Sabharwal said, I'm at UCSF, Benioff Children's at Mission Bay in San Francisco. So nice to see everyone this morning. I have no disclosures. So this is an unbelievably huge topic, and I'm actually going to probably capitalize on my extra few minutes this morning because it's nearly impossible to get through limb deformity, limb differences in 20 minutes or so. But I will try and hit a couple of highlights and give you a few examples. So first, we'll cover the normal growth and development of the lower limb, because obviously to understand pathology, we need to understand normal physiology. We'll talk about coronal, torsional, and linear growth of the lower limbs. And then we'll talk about some types of limb differences, including in the coronal plane, the torsional plane, limb length differences, and then the more complex and congenital limb deficiencies. So one of the most common types of limb differences that we see is in the coronal plane. So when we're looking at somebody in the frontal plane, and the way that we assess that is with the patient standing or supine, looking at them from the front with the knees extended, the patellae forward. We see neutral alignment when the knees and ankles both touch. You can see in these little stick figures here, nice straight legs, right? That's what's normal. But genuvarum we describe as when with the ankles touching, there's space between the medial femoral condyles, and genuvalgum we refer to as when the knees are touching and the ankles are apart, as you can see from the pictures. But what is normal, right? So the pediatric skeleton is a moving target throughout childhood. And when we have, little toddler, 12 to 18 months old, those legs are commonly in varus. Usually around 2 years of age, the legs are straightening out. They look very knock-kneed by around age 3, 4, or 5, and then typically by around age 6 or 7, the legs straighten out to their normal alignment. So again, just the pudgy little toddler bowed legs up top, 2-year-old straight legs and pink tights here. We've got the knock knees of a 4-year-old and then the straight legs of a 7-year-old. And again, just in graphic format, we can see that the swings are large from about 15 degrees of varus to over 15 degrees of valgus in some cases, evening out at about 5 degrees of valgus in the long term. And then along with coronal plane development, there's also a huge change in torsional alignment as a child grows. So when kids are born, they're born with a significant amount of femoral anteversion and often internal tibial torsion as well, sometimes even metatarsus adductus. So that limb is quite twisted when kids are born, and it will gradually unwind through growth in a natural process. The way that we evaluate the twist of the tibia, which we call tibial torsion, is by the thigh-foot angle, right? So that's the way that the foot is relatively rotated compared to the femur. And this is normally internally rotated at birth and swinging externally throughout growth, usually over the first half of a decade or so. And then femoral torsion, right? This is something we commonly see. We see kids with in-towing a lot in our clinics, but femoral torsion is very common at birth. And you can see from the pictures here, you've got the internal rotation of the femoral neck rotating towards the knee. And that will lead to in-towing, right? And this is a very common part of being a child. You can see in the graph in the corner that femoral torsion begins around 40 degrees when kids are born, and it will slowly decrease over time throughout the first decade. So again, that's a normal part of childhood development. And then it's also very important to understand the linear contributions to growth, right? So obviously kids are growing at a rapid rate and throughout their childhood. And we've got contributions to growth of the lower limb in multiple places. So the top of the femur grows about 3 to 4 millimeters per year. The bottom of the femur is the biggest growth source, and that's about 1 centimeter per year. The top of the tibia contributes about 6 millimeters per year, and the bottom of the tibia about 4 to 5 millimeters per year. And then the velocity of these changes, so the highest velocities are occurring at the infantile period, and then slows down significantly between age 4 and 10. But then when they hit that adolescent growth peak, it will rapidly increase again to the velocity of an infant, and then rapidly decline after puberty. So that's all the normal part of development. But when this coronal and torsional and linear growth go awry, we end up with limb differences, and we'll hit a couple highlights of these. So first, how do we think about limb differences? So the first way I think about it is where it's happening. Is this a diffuse problem of the entire limb, or is it a very focal problem at one spot? And then why is it happening? So this can be a nutritional or metabolic cause. This can be a genetic or a bone dysplasia cause, or it can be from a trauma or an infection, or in some cases it's idiopathic and we don't know why it's happening. And then when it happens is also an important thing to consider. So some of these issues are congenital, meaning that they've always been there. And this can be result of failure of formation of the limb bud, duplication of parts of the limb, overgrowth, undergrowth. It can happen, in utero from a constriction band, or it can happen as a result of a skeletal dysplasia, which is an inborn genetic error. Or these can be acquired causes. So things caused by an event, or abnormal development with growth. And this can also include those gradual changes due to nutritional or metabolic abnormalities. And then, of course, we think of the plane of deformity. So we look at deformities in the coronal plane, so angular abnormalities. And this could be varus or valgus at the hip, the knee, the ankle. We think about torsional abnormalities. These are a very common cause of complaint, not a common cause of disability. And then limb length differences, of course, are a big topic. And then there's some that are more complex and are actually a combination of multiple planes of deformity. And these would be the severe congenital malformations and deficiencies, where we really have all planes involved and we have to think about all things at the same time. So I'm going to start with a few examples of coronal plane abnormalities. And so the way, first of all, that we assess coronal plane lower limb coronal alignment is, in addition to the physical exam and looking at the patient, we're also going to be looking at full-length standing AP radiographs from the hips to the ankles. And again, it's very important to get the patellae forward and the knees fully extended so you can get an accurate view. And these are a couple examples of a limited bone survey, which is the way that we assess them radiographically. And then in order to assess the coronal plane alignment, we use the mechanical axis deviation. So we're drawing a straight line from the center of the hip joint to the center of the ankle joint. We're looking at where it crosses the knee. And in a normal alignment, that mechanical axis should be within 0 to 3 millimeters of the center of the knee joint. But in a coronal plane abnormality, it's going to be displaced from that. So we generally tolerate about the middle 50% of the knee. But alterations more than that can really affect joint health and can lead to pain and morbidity. When we really want to get into the nitty-gritty of understanding exactly where a deformity comes from, we're going to look at every single angle here. We're going to look at mechanical axis lines and anatomic axis lines, and we're really going to be able to drill down on where that deformity is coming from specifically. So a couple of examples of coronal plane abnormalities. So when we think about valgus, the most common thing is just idiopathic genivalgum or knock knees. Now, keep in mind, this is totally normal in a child from age 2 to 6. There's no role for bracing here. It's ineffective. And we just watch and wait for this to improve. But there may be some kids, particularly those who are obese or ligamentously lax, who might have hypoplasia of the lateral femoral condyle, where this actually will be persistent and may need to be treated later on in their adolescence. And then there are the pathologic genivalgum examples. So this could be post-traumatic or post-infectious, for example. So this is often going to be unilateral. Fractures and infections can commonly cause this. So for example, in the top left corner, you see a picture of what we call a Cosen's fracture. And that's because it can lead to this Cosen's phenomenon, where there is this overgrowth medially as the fracture heals, that can lead to genu valgum. Now, normally this resolves after a couple of years, but it's something that has to be closely monitored. And then there can actually be fractures which directly impact the growth plate and can lead to growth arrest and malalignment. So these are some examples of a focal problem. And then the diffuse, right? So we talked about focal versus diffuse. Diffuse genu valgum can include metabolic abnormalities of calcium and phosphate. So for example, rickets, and rickets often causes this sort of interesting windswept pattern, but renal osteodystrophy can do this too. And then of course the dysplastic. So again, these are diffuse problems caused by inheritable diseases that have genetic abnormalities of the cartilage and or bone. So these are some examples. On the left here, you have a patient with OI, or in the middle, a patient with Olier's disease, and on the right side, a patient with multiple hereditary exostosis. So all of these can often lead to coronal plane abnormalities as well. The very common cause of genu varum that we see is Blount's disease. So this is a focal problem, right? This is a focal mechanical disease of the posterior medial proximal tibial physis. Risk factors include obesity, early walkers, and certain races and ethnicities, especially African Americans. This can happen either early in a small child, a toddler, or it can occur later on in adolescence. And if not treated appropriately, this can lead to physeal closure on the medial side and severe progressive deformity. And then other types of pathologic genu varum would be, for example, by cancer or radiation. So there's a patient of mine with a radiation-induced genu varum. The diffuse types of genu varum can include from skeletal dysplasias. Again, this is a patient with OI on the left and a patient with achondroplasia on the right. So those are a few examples of coronal plane abnormalities. Also, just to mention some torsional abnormalities. I put torsional problems in quotations because these are very frequent causes of concern by parents, but usually not real true problems. So one of them being metatarsus adductus on the left with curved feet. And this is something that often resolves on its own. Very commonly, you can see a picture in the middle of a toddler with in-towing. That's very commonly caused by tibial torsion, which again needs reassurance and resolves on its own. And then in-towing, which is the problem of femoral anteversion, which again typically resolves on its own and almost never causes a functional problem. But where we do see sort of a quote unquote limb deformity with torsion can be with these more severe combination deformities. So for example, these are a couple of cases of miserable malalignment syndrome, which involves significant femoral anteversion and then corresponding external tibial torsion, and this can lead to knee pain and morbidity. And then, of course, limb length difference is a big topic, and there are so many different causes of this, but one thing to discriminate between is the functional versus the true causes of limb length difference. So functional or apparent limb length difference can be caused by soft tissue contractures. So if somebody has a knee flexion contracture or equinus, that's going to change the relative apparent length of the limb. This is common in spasticity. So a patient with CP and hemiplegia, while there may be a true limb length difference, right, and often cases that of more affected side is shorter, they often will have a knee flexion contracture, which makes it look like that leg is relatively shorter, even if the structural difference is not that big. And then hip pathology, hip dislocation can also make the leg seem relatively shorter, even if the limb is the same length. And then there's the structural causes. So thinking of congenital types, right? So there are lots of causes of this, but I think of them as sort of intrinsic versus extrinsic. An intrinsic cause may be an overgrowth syndrome, such as hemihypertrophy, with or without Beckwith-Wiedemann syndrome, or undergrowth, such as hemiatrophy. And then there can be these errors of formation, such as the hemimelia category or the proximal femoral focal deficiency. And then the extrinsic causes, such as amniotic band syndrome or in utero trauma, which can also truncate a limb. And then, of course, things caused by tumor or neoplasm, such as fibrous dysplasia or Olier's disease that can shorten a limb, vascular abnormalities will often have a significant effect on limb growth. So a dramatic case may be in a case of Klippel-Trenaunay syndrome, where the leg will be vastly overgrown due to the vascular malformations. And then, of course, physeal injury from infection, trauma, and by injury to a physis, that can lead to significant shortening of a limb. So when we measure a leg length difference, again, we're relying on this frontal X-ray, which we refer to either as a scanogram or a limited bone survey. And very important to make sure that those knees are forward, and those knees are straight in order to accurately assess limb length difference. And then we do some math. So we're going to draw some lines across the tops of the femurs, the bottom of the medial femoral condyle, and the tibio-talar joint. And in order to assess leg length difference, we're going to first evaluate the length of one femur versus the length of the other femur in a vertical direction. And in this case, we see that the right femur is about 1 centimeter longer than the left. Then we also measure the difference of the right tibia and the left tibia. And in this case, we see that the difference, the left leg is about 2.6 centimeters longer than the right. We're also accounting for a foot height difference here, which is about 0.4 centimeters, left side higher than right. And then we add all these things together. So in this patient, it all comes out to about 2 centimeters of leg length difference. But at least now we know where the differences are coming from. And if we need to lengthen a particular limb segment, we're going to know where to do that. So a type of overgrowth causing limb length difference that we often see is hemihypertrophy. So this is defined as an over 5% difference in the bone and soft tissue of one leg. So this is with normal lymphatic and vascular systems, just with overgrowth of the soft tissues and bone. It can be idiopathic, or it can be syndromic, most commonly associated with Beckwith-Wiedemann syndrome. That's the most common genetic overgrowth syndrome that causes this. And it can be associated with abdominal tumors. And so we need to be careful to make sure that these patients are being screened by their pediatricians and healthcare team. And then the sort of other side of that is hemiatrophy. This isn't typically syndromic. The cause is unknown, and it happens in otherwise healthy kids. This is a unilateral bone and soft tissue undergrowth. One of the things you have to ask yourself when you're seeing a patient with one limb that's just proportionally bigger to the other is the small leg the abnormal one, or is the big leg the abnormal one? And that's something you just have to do a careful physical exam for. Usually one limb will appear significantly different and sort of doesn't match the child. And then, of course, we have limb length differences as a result of bone neoplasms or bone lesions. And so these are some examples. For example, Olier's disease with multiple enchondromata, and that can cause a limb shortening. Fibrous dysplasia can also lead to shortening of the limb, and also these lesions can lead to malalignment as well. And then when we think about limb length discrepancy over time, right, we need to remind ourselves of how they act. So a lot of these limb length differences that we see that are the congenital type will be a proportional discrepancy. And that means that the proportion of one leg, the size of one leg will be consistent throughout time. So this law of proportionality in a type 1 limb length difference, the congenitally short limb will be about the same percentage of the long bone at birth and at skeletal maturity, as opposed to a growth plate injury, for example, where you have an additive discrepancy every year, okay? And then the last topic that I'll hit on is the limb deficiencies. This is a huge category, and it's very complex. It involves coronal and torsional and linear deformities, so all of the above. And these can run from relatively mild problems to, huge problems requiring limb salvage or amputation. But the basic principles here, it's a wide spectrum of congenital limb differences. The cause is often unknown, but will usually is presumed to involve a spontaneous genetic error in limb bud development in early fetal development. Okay, so this could be an interruption of the arterial supply, or it could even involve intrauterine amputation from amniotic bands, or a teratogen that affects a fetus at a particular point in its development. And then, you always have to remind yourself, when there's one abnormality, look for another, because there may have been some kind of in utero insult. But these kids often, these kids will have normal intelligence and a high propensity for adaptation. And so they can often do great with complex care. But the treatment is usually individualized, because these are such a large spectrum of deformities. The treatment may be divided into multiple stages. But again, just sort of a reminder of embryology here. So the appendicular skeleton is formed by the lateral plate mesoderm. The limb boards begin forming at around the 4th week of gestation. And so this is very early on in pregnancy that a limb bud can go awry. And usually the toes are separated and the limb is completely formed by day 56. So all of this is happening very early on. And again, just another picture to show the sort of sensitive portion of fetal development. But a couple examples would be, congenital short femur. So this is a femoral hypoplasia, right? Different than hypertrophy or hemiatrophy. It involves distal femoral valgus with a hypoplastic lateral condyle. And often there are some hip abnormalities as well, such as lower extremity or hip external rotation and retroversion. A more severe form of that is proximal femoral focal deficiency, ranging from anywhere from a mild coxavera with a little bit of shortening to a complete absence of the hip or femur. And then fibular hemimelia is something we see a little bit more commonly. This is a shortening or absence of the fibula, and it has an incidence about 1 in 40,000. Most common lower extremity bone deficiency. The limb length difference is proportional to the amount of fibular shortening. Along with this, we see genu valgum typically with a hypoplastic lateral femoral condyle. Classically, they have a ball and socket ankle with instability, and then often missing lateral raise of the foot, as well as tarsal coalitions. Additionally, they might have an absent ACL or knee instability, so that's something you have to be very mindful of when lengthening these children. They may also have some component of femoral deficiency and retroversion, and then kind of have associated foot deformities. And then the last thing is tibial hemimelia. This one is extremely rare, but often very complex, and happens in about 1 in a million kids. There's always a clubfoot because the tibia is missing in some capacity. It may be autosomal dominant and bilateral in up to 50% of cases. And occasionally they can have upper limb deformities or other skeletal or non-skeletal abnormalities as well. Sort of the old system of classification is shown here, which has been modified over time, and but involves a relatively complex option set for surgical management, either with limb salvage or with amputation in many cases. So that is it. I think I got through everything. That was just a summary of some limb differences: coronal, torsional, and length difference. They can be focal versus systemic, congenital or acquired, and mild to extremely severe and complex, with complex solutions. So that is all I have for you. Thank you so much.